Yes, sure.
Okay.
Go ahead.
Okay. Good afternoon, dear all audience. This is the second day of International Congress of Microbiology in Iran. And I and my colleagues are going to present you a panel on new challenges over treatment and management of COVID-19 patients. First of all, I should thank scientific committee to choose us and all of you for taking time and hearing us. And we have 2 or 3 presentations and 3 well-recognized scientists, speakers working and cooperating with me because we want to have a brief and comprehensive discussion about as much as possible the all aspects of COVID treatment. And I know that many of you have many questions that you want to ask, especially from Dr. Yazdanpanah and Dr. Shokouhi as infectious disease specialties. So I do my best to moderate the panel very well and on time. So let us start with Dr. Yazdanpanah. Let me briefly introduce him to you. Dr. Yazdanpanah is the head of infectious department in Claude Bernard University Hospital in Paris. And he has so many publications, well-known and internationally recognized publications. And he's the full professor of infectious disease. And I know that he had many interesting presentations worldwide, and he's a very nice person and a scientist, really scientist. So we'll start with him about the new challenges or all challenges in management and treatment of COVID patients, especially in European countries and especially in Paris. In case of any question, I kindly ask the audience to write their questions in the chat box. I will summarize the question. And at the end of the panel, we will have a discussion about the comments and the questions. Let us start with Dr. Yazdanpanah. Dr. Yazdanpanah, if you are ready.
Thank you. So I hope that you see my slides well. So first of all, thanks a lot for your invitation. So indeed, I'm going to talk about COVID-19 treatments and an update on where we are today. I think that everyone knows this figure where you can see that probably COVID-19 disease is not one disease, it's several diseases. So regarding treatment, we should be very careful because in different phases of the disease, we should probably use different treatments. In a very simple way, we have a viral response phase and a host inflammatory response phase, but probably this is too simplistic and things are even more complicated than this. However, this is important. This is the first patient we received in our hospital in Paris. It is the first patient actually in Europe that was hospitalized. And this was in January 2020 when we saw that when the viral load excretion was almost 0 at day 10, the patient started to have a pneumonia. So this actually visualized well the fact that probably the anomalies and the pneumonia we see, a lot of this is related to the host inflammatory. And this, of course, is very important in the treatment that we're going to decide for patients. Currently, and I will come back to that, what we do have as validated treatments are treatments during this hyperinflammation phase and for hospitalized patients, and they are steroids, anti-IL-6, Tossilyzumab, and anticoagulation. This, we can say that are those that now are accepted by WHO as validated treatments. I'm going to go a little bit over this. So you know that steroids, the first study actually that really told us, although people were starting to use that steroids could be active. It's the recovery trial, but you can see other trials that are here that also demonstrated that steroid use can be of benefit and is of benefit with in hospitalized patients a decrease in mortality of 30%. Usually we use dexamethasone, but of course we can also use other steroids like methylprednisolone or hydrocortisone, although there are much less insight to that. But that is now validated. And the other thing is that very important is that we should not use it in ambulatory patients. That is very important because in France, many general practitioners, for example, give steroids to patients before they need oxygen, and that's not good. So steroid in patient at hospital, and even in hospital, we still have questions. For example, you can see in this study that we have done in France that probably the effect is higher when you have more oxygen than when you have less oxygen, that the effect is probably higher when you have an inflammation. And you can see that the effect is even very high when you have high oxygen and high CRP. The question that remains is, even in hospitalizations, when it's the best to start. We should only use it in patients with oxygen, but when to start. At which dose? We currently use it 6 milligrams of dexamethasone, but there are some studies going on comparing 6 and 20 milligrams. The duration, 5 days, 10 days, which one we should use. And the other thing is that maybe there's also an issue about age, at which age, whether patients who are older and patients who are younger, it's the same thing. So these are questions that remain, although we should use in this patient, of course, steroids. The second validated treatment is Tossilyzumab, which is an IL-6 antagonism that actually was demonstrated in several studies giving a benefit. And this is a JAMA paper, which is a meta-analysis by WHO that shows that administration of IL-6 antagonism, and especially Tossilyzumab, is associated with a lower mortality at 28 days. So you can see that in this meta-analysis, we really have this trend. And again, I think that where we see it the most is with Tossilyzumab. And the other thing is that certainly you can see here an effect which is higher when you use Tossilyzumab with steroids. You can see steroids and Tossilyzumab decrease by 23% mortality. There are much less data on the other IL-6, which is Sarilumab. So this is, and you can see here is on mortality, and here you have the same thing basically with other outcomes like ECMO, mechanical ventilation, or death. And again, here you can see that you have 30%, but use it with steroids. And what we currently do and this should be also a little bit explored, is we first put steroids. After 48 hours, if you don't have any improvement, we add Tossilyzumab. So this, we almost do it in all the patients. Now, WHO has put this as standard of care in hospitalized patients. The other validated treatment is anticoagulation. About a month ago, you have these two papers that were published in New England Journal of Medicine, where they used and compared therapeutic anticoagulation in non-critically ill patients and in critically ill patients. In non-critically ill patients, they compared therapeutic dose of anticoagulation with heparin, with actually prophylactic doses, and they saw that therapeutic doses increases the probability of survival. In critically ill patient, it did not result in a great probability of survival. So this, we have not yet solid meta-analysis by WHO, who is currently doing it. These two studies say that in non-critically ill patients, you should use curative doses. In ICU patients, prophylactic doses. Iran has actually published also a paper in JAMA comparing intermediate dose versus standard dose in critically ill patients without any improvement. It is still a question. We still don't know which dose to use. What happens right now in our unit, and there is a big French clinical research or clinical trial going on. We currently use, of course, everyone, prophylactic doses. In those with high BMI, we use curative doses. And those in the middle, we use actually intermediate doses. So it's sure that we should use at least prophylactic dose in everyone, but results concerning curative dose is for now not that strong. And I know that you have published on the same issue. So this was regarding the drugs in the inflammatory stage. Now, antivirals. So these, I should have put in 2020 because we have all these drugs. And basically, many of these drugs now we show that doesn't work. And in some of them, there are question marks. The first thing that, so I just want to say that hydroxychloroquine doesn't work. Kaletra doesn't work. That is for sure. Favipiravir doesn't work. I want to say a word about ivermectin. Personally, I think that it doesn't work because we have model animals that show that you need very, very high doses that not tolerated by patients to have an antiviral effect. However, clinical trials are ongoing, and we should not use this drug in clinical practice, but only in clinical trials. We had last week the results of a trial in Brazil and Canada called Together Trial, a well-designed and conducted clinical trial that showed that ivermectin doesn't work. We should be very careful. This is August 26, 2021, an official CDC health advisory that see that there are many ivermectin prescriptions, and there are reports of severe illnesses associated with use of products containing ivermectin. So I think we should be very careful regarding this. There is currently no proof of the efficacy of ivermectin. There was one meta-analysis that was published on OFID that was retracted, actually, so we should really careful regarding that. The other drug that I wanted, because I know that in Iran is used, is remdesivir. So remdesivir, we had the NIH trial, the ACTT, that showed actually that it's a double-blind placebo-controlled trial in USA. And it showed that not on mortality, but it was not significant impact on mortality, but it reduced the time to recovery by 30%. This was the NIH trial. The Solidarity WHO trials, where there were many Iranian and French patients, there was no effect on mortality. When this paper that was published in New England, it shows that basically you can see here, in those with low oxygen, there is maybe something, but it's not significant. Whereas in ACTT, they find it significant. In high dose, it's for sure, neither in an NIH trial nor in WHO trial, any efficacy. And that overall, when you do the meta-analysis of the trials, it seems that in high-risk groups with high ventilation, invasive ventilation, it doesn't work. In low risk, this meta-analysis, it shows that it doesn't work. Currently, what NIH people are saying is that maybe it works in low risk without ventilation. We have done a French trial. These are the results of the French trial that will be published soon in Lancet Infectious Disease, when we show that on the 7-point WHO ordinal scale, there is no significant effect of remdesivir. You can see the evolution of viral loads that we didn't have neither in NIH trial nor in WHO trial. And you can see there is no difference in the slope of the viral load decrease for antiviral, which is remdesivir, between remdesivir and the control. So currently, we do not use remdesivir in France. I know that in the USA, it is still recommended for patients, however, only those with low oxygen. We are conducting, the French trial with NIH, with Norwegian, with Canadian, a meta-analysis regarding this to better understand. But currently, we do not use remdesivir. The other family, very important, that I think probably there are some good results, are monoclonal antibodies. So you have many different families, the product by Lilly, the product by Regeneron, the product by AstraZeneca, the product by GSK, and many others. There was this paper published, I think, a few weeks ago in July, or maybe in June, showing that in outpatients, among high-risk patients, the combination of Lilly, BAM, and etesevimab led to a lower incidence of hospitalization if you give it early. So you can see it's actually 2% when you have the monoclonals of hospitalization or death versus 7%. And you can see although the difference is not high, a difference in the viral load decrease. However, we should be very careful because BAM, etesevimab from Lilly do not work on Delta variants. This is very important. So that means that In France, we cannot anymore use it because we have only Delta, and probably in Iran, it's the same thing. It doesn't work neither on Beta and Gamma. There are also results for Regeneron and Roche monoclonals. So they have the advantage of working on Delta variants. So this is the first paper published basically in New England, or you can see that there is an effect, but only, you can see the decrease in viral loads only in seronegative patients. It means that if you use it early and in patients who have not seroconverted, you may have an effect. In those who have already seroconverted, no effect. And you can see that the effect could be significant, especially those at risk. So here, the objective is in patients at high risk of hospitalization, immunosuppressed, diabetics, obese, you start as soon as you have the diagnosis with these molecules, and then you decrease the risk of hospitalization. You can see here from 9 or 10% to 2%, for example. But you should give it very early, within 5 days. So this is something we have expanded access to in France. So it's not validated, but we have expanded access. We can use it, but it's difficult for outpatients because it is used IV 1 hour. So for someone who's outpatient, it's difficult. Last week, we had it a little bit earlier, but the paper was published recently on the fact that this same monoclonals from Regeneron Roche, they can decrease also when you give it to the contact of positive patients, the probability of evolution to symptomatic COVID. And the other thing that was good is that the use was subcutaneous. So subcutaneous Regeneron prevents symptomatic COVID in previously uninfected household contact of infected patients. And even those who are infected, you can see that the viral loads of those infected with monoclonals are lower than non-monoclonals. So this is, of course, important. And again, this is not basically validated, but in France, we use this drug in expanded access for high-risk patients, contacts of those who are positive if they are not vaccinated. How about these drugs in hospitalized patients? So these are results from recovery trial, where they use in hospitalized patients monoclonals. And when they find that monoclonals, and the monoclonal they used was Regeneron, reduced mortality by 20%, but only in seronegative patients. So if you have a patient in hospital, you do a serology. If it's negative, you can use it. If not, no. You can see the differences here. There is this meta-analysis. We should be careful about the results. This is only one study, not yet published. But what we can see is that it seems to probably better work in patients who are less than 80 years, and probably when you give it early, less than 7 years. And there is no data on those who are invasive ventilation. So we don't have yet expanded access to that. It will come. In Italy, they have already expanded access to that for hospitalized patients, but only if they are not on invasive ventilation. So basically, if I can tell you here a summary of what we do and what is validated in France. So in hospitalized patients, we're doing steroid, We are doing Tossilyzumab. I should have put anticoagulants, of course. And the Regeneron monoclonals in seronegative and without invasive ventilation, not validated yet, but we are starting to think about this. In outpatients who are at risk, if we capture them within 5 days, we use again Ronapreve, which is the combination. So for example, in immunosuppressed patient. In post-exposure, in at-risk patient who do not respond to vaccine, who are not vaccinated. And we have also started thinking of using this drug in at-risk patients who do not respond to vaccine. Very immunosuppressed patient like transplant patients. So this is currently what we do. And these are the first generation monoclonals. Probably there are others coming. One of the others is AstraZeneca. So there was a study where they use it in prevention on pre-exposure for prophylaxis, given some effect, not yet published, which shows that it could be interesting, and it has a long half-life, about 6 months, so it's or even 1 year. It could be interesting. And we are currently in an European study comparing also in hospitalized patients AstraZeneca versus placebo. I'm going now to be more quick because I'm a little bit late maybe. Plasma, convalescent plasma. One study shows that it could work in outpatients, but it's more complicated. But recovery have evaluated in hospitalized patients, and there is no effect. No effect. There are some specific patients, like those on anti-C20, profoundly lymphopenic, where we can't use convalescent plasma, but honestly now we use in more in patients monoclonals, basically. Other drugs, interferon, maybe. So in hospitalized patient, interferon doesn't work. But if you give it early, there one study on small number of patients saying that it may work. There is one study saying that it doesn't work. So there are some other studies going on. You have results of the principal trial showing that inhaled budesonide may, in outpatient, decrease the risk of hospital admission and death. But results of this trial are extremely actually borderline, because basically they find a decrease in time to sustain recovery. You see, 23 to 28 days, but time of elevation of symptoms, it's the same. You see, and they don't have a very significant results on admissions or deaths. So something to still, and we have a study on this in France too, it is a nice direction, but not yet validated. What are the other drugs? Molnupiravir, which is an antiviral drug, which is oral drug, so that is very nice. There was a presentation in ECMID in June showing that it may work in outpatients, but not in hospital. Antivirals, they may work if you give it early. There is a phase 2-3 study on a anti-protease from Pfizer, already available, important and interesting. It is also studies going on DARPins, that it's an emerging class, actively being developed in ophthalmology that may work, but very early. So if I try to conclude now, what is under evaluation that for me could be interesting. Other monoclonals than Regeneron in prophylaxis. In early phase, oral antivirals, and I said molnupiravir, Pfizer drug. I didn't talk because I didn't have time, but antidepressors, there have been some results this week. We have to look at it. Enhanced steroids, interferons, still monoclonal antibodies, and also some anti-inflammation drugs like anti-C5aR, anti-BTK, anti-JAK, or also the WHO who is evaluating anti-TNFs. So these are drugs that are under evaluation. But I think I will finish there. And the most important thing I want to say is also do not use the drugs that we don't know if they are active. Thanks for your attention.
Thanks, Dr. Yazdanpanah, for your nice presentations. I know that there are many questions, but I think they will be better discussed at the end of this panel. As I know, we have no Dr. Tehran to present, so if Dr. Shokouhi wants to add anything, we can have time for Dr. Shokouhi. If not, I can proceed to my presentation.
It's better to discuss about these problems at the end of the
Okay.
webinar. I guess that was better. Yeah.
Okay. So let's continue with my presentation about steroid challenge. Of course, Dr. Yazdanpanah presented us very comprehensively and of course briefly many drugs in different phases of COVID-19. And maybe I do not have any further thing, but I think it would be better to overview some aspects and some questions about the steroid usage in COVID-19. As you know, the COVID-19 patients, yeah.
Sorry for the interruption. Could you make your slide in full screen mode?
Yeah.
Thank you.
Okay. Okay. As you know, the COVID-19 patients pass maybe 2 or 3 phases during their illness. The first one is viremic phase, and the other one inflammatory, and then many of them or many of hospitalized and severe patients enter the phase of post-pneumonia or systemic inflammatory or cytokine storm syndrome. There are many publications about the steroid usage, when to start them, and the type of them, the type of a choice drug, the duration, and the dosage. And many publications, and with I can say with any definite conclusion, because the disease is new and maybe it takes more time to answer the questions. The most steroid agent that had been studied is dexamethasone, and in a large study, as you know, that it decreased 28 mortality in hospitalized patients, and in the dosage of 6 milligrams per day. But other studies studied the other molecules such as hydrocortisone, methylprednisolone, or even oral prednisolone. And in most of them, they believe that methylprednisolone and dexamethasone are better agents than the others. Many believe that methylprednisolones deposits in lung more than other agents, and because of that we use methylprednisolones such as pulse therapy in many in lung inflammatory syndrome such as vasculitis. And so with inspiration of these mechanisms, we can use methylprednisolone in COVID patients in inflammatory periods. But I think one of the most problem especially in Iran, is that we use steroids very quickly. I think before the inflammatory phase, and I think in my opinion and in my clinical practice, every day I see and visit patients that received steroids, even high dose steroids, before they use antiviral drugs or before they enter the inflammatory or cytokine storm period. And as Dr. Yazdanpanah, it is not prudent, it is not reasonable to use dexamethasone or other steroid agents in outpatient settings and in those patients who do not need supplemental oxygen. And I think that when we use steroids too quickly, it may be more harmful than beneficial. And maybe, in my opinion, there was no head-to-head comparative studies published. But in my opinion, those patients who received steroids early in the phase of disease may accelerate, may progress to the more severe disease and needs hospitalizations more than those patients who didn't receive or who doesn't receive steroid agents. So the first, I think the first home message to be taken. Oh.
I'm so sorry. You only can see the slide related to the time and doses.
Okay, I will change the slides. Okay, yes,
yeah.
yes, yeah.
Okay.
So
now we can see the slide, any contraindication.
Yes, yeah. So I think the first taking home message is that we should not use start steroids too quickly or very early or in outpatient setting. But in my opinion, or this is a challenge in my clinical practice, I think there is no a definite line between viremic phase and inflammatory phase. And there are many times overlapping that the patients overlaps between these two periods. So the time of steroid administration, I think it's very important to have beneficial effects in mortality rates. And the dosage, if we use dexamethasone, according to many published guidelines, we do not use more than 6 milligrams per day and do not use more than 10 days. But if you use methylprednisolone, because of the lung deposition effect of these agents, we must not use more than 1 milligram per kilogram per day. Now in Iran, we use much more doses, and for example, high pulse therapies with 500 milligrams and 1 gram per day for more than even 7 days or 10 days. And I think because of this overuse of high dose of steroids, we have so much complications such as fungal infections and opportunistic infections. And as you know, many of the patients with COVID disease in the second week of treatment are at risk of superimposed bacterial infection. So with the use of this amount of steroids, we may render them in the risk of many significant infections. Another thing is that we must be precautious about non-infectious complications of steroids, especially about the patients who are under mechanical ventilations. we have a problem with critical illness neuropathy and also wasting myopathy, that steroids expedite this myopathy and get the patients more difficult to be weaned from mechanical ventilators. So it seems that in Iran, I don't know whether in other worlds the practice is the same. We use steroids more than the recommended dosages and more than the beneficial dosages. And so we confront with wide range of their complications, including infectious complications and non-infectious complications. For example, as you know, many of our COVID-19 patients suffer pneumothorax, pneumomediastinum, and the occurrence of pneumomediastinum and pneumothorax complicate the course of disease because the patients must have 2 chest tube insertions. Then these chest tubes are another source of infection, hospitalized infections. So the course of disease would be more and more complicated. So be careful about the barotrauma induced by steroids in your patients, and we must not use the steroids for those who are at higher risk of developing complications. And these patients are especially our older patients. So we do not recommend the use of steroid in patients older than 70 years old. And as you know, a bulk of our patients in ICUs and in respiratory care units are elder patients. But we use the same steroid dosage, such as younger patients to these patients. For example, women with diabetes, hypertension, coronary artery disease, obesity, we administer to her 1 gram methylprednisolone daily for 5 days or 7 days. So maybe the 28 mortalities of oxygen dependency and its complication decrease. But as a pulmonologist, I see many patients, especially Iranian, with tuberculosis, fungal infections, because we live in an area with endemic tuberculosis, and because of pandemic and crisis issue, maybe we have no so much time to check patients for occult tuberculosis, for PPD testing or IGRA testing. So in case of any steroid administration, we must balance with advantages and disadvantages, and see what we want from the steroids. In my practice, I do not use a steroid whenever there is any suspicion about viremic phase. In my belief, when there is leukopenia, the virus is still active, and maybe the high dose of steroids before antiviral therapy may accelerate the disease course, or when the inflammatory markers such as CRP, interleukin, IL-6, or other inflammatory markers are not so much high, but the leukopenia is very significant. I think we must be cautious about the usage of steroid. At this time, further studies are needed to evaluate the advantages and disadvantages of other steroid agents, the durations, the types, and the way is still going, and there are many questions to be answered. But I try to share my experience about the usage of steroids in patients. And for me, one important taking home message is that do not use dexamethasone or any high potent steroids in those patients who are at risk of hospitalizations, but still are not hospitalized and do not require supplemental oxygen, because I see day by day more and more patients who use dexamethasone too quickly in early phase of their disease, and this result in hospitalizations and more severe disease. I wish I can deliver my messages to your dear audience. My presentation is now finished, and we are ready to have your questions and comments, and we will go to the discussion at the end of panel. Dr. Shokouhi.
Thank you for your nice presentation and for Dr. Yazdanpanah. So first of all, I want to thank you two guys to go through our problem. You know, our main problem is how to use the drugs, how to terminate the drug, and how to manage their complications, mainly corticosteroid. So for your, I have some opinions about your presentation, Dr. Asadi. Our problem in my country, most of our audiences is Iranian, I guess. As an outpatient and nowhere get any CAT scans like here in Iran. All of the patients here in Iran got some CAT scans, not one CAT scan, and come to my office and said that, please take a look to this CAT scan. How many % of my, my CAT scan
line is involved?
Yeah. I have a lot of problem with this sentence. So unfortunately, many of my colleagues get CAT scan from the mild and mild patient to, pull it in moderate phase, because moderate and mild got this, this is the, difference between these two. A mild case with an involved CAT scan, we call it moderate case. So,
Sorry for the interruption, Doctor, we cannot see your slides.
I don't have any slide. I just a panelist. I don't have any talk here.
Okay. Sorry for the interruption.
Okay. And as I told you, after getting a CAT scan, they can see a patch or so many patches in their CAT scan of the thorax, and say that, oh, your lung is involved and you have to get some steroids and some antivirals. So yes, about the steroids, as you told us that there is a lot of problems in the using of the corticosteroid in Iran. Unfortunately, all of my colleagues actually think that they have to use corticosteroid for moderate cases. One more time, I just interpret moderate case is a mild case with an involved CAT scan. So because of that, most of our patients, I mean, my patient and your patients, when they approach to our office, they get 2 days, 5 days of dexamethasone or prednisone as an oral agent. And when they came in, we can see, as you told us, they can go through the CRS more rapidly. Actually, there is another problem in these kind of patients. because we in simple patients with no steroids, we anticipate to go to CRS at most at 14 or 15 days of the disease. But in these kind of patients, they can go through the CRS in 18 or 19 days. The CRS can postpone, and it's it's very hard to differentiate these kind of patients with some other complications of the of the COVID disease, because in 18th or 19th days after starting the disease, when the patient come through our office with a saturation of 90 or 88, the differential diagnosis is completely different in simple cases and in corticosteroid in patient with getting corticosteroid. And as you told us, yes, it's our problem in my country. In national guideline, we bold this problem with, please do not use corticosteroid before starting oxygen for the patients. But unfortunately, most of my academic colleagues actually just starting corticosteroid before supplemental oxygen. It's our problem. Yes, you nicely go through it. And one thing that you actually was your question. What's the difference between viremic and inflammatory phase? You said that. I have a question for you. Do we have any viremic phase? You mean viral phase? Yes, not viremic, yes. Because we do not have any viremic phase. Viremia is I think it's better to do not it's not as Dr. Yazdanpanah said, that we cannot differentiate the phases in this disease. It's complicated. It's complicated, and we cannot differentiate this. But we can say that before dropping the PF ratio or SF ratio, please do not use corticosteroids.
Yeah.
This is I think this is fair. And the other issue that you actually go through it is you said that before using antivirals, please do not use corticosteroid. Do we have any antivirals here? We do.
As you see,
we don't have any antivirals.
No, and now we have remdesivir clinics, as you know. And in many of them,
unfortunately, yes.
And many of them, they inject dexamethasone and remdesivir and enoxaparin for all of patients.
Yes, unfortunately. Yeah. I actually thank you for go through this problem of my country. In National Committee of COVID, actually, we have a lot of problem in regarding this, clinics.
Or we have some hospitalized patients, especially in university hospitals. Mm-hmm. For example, the patients would be admitted in nighttime or late in evening. So the residents or the interns prescribe both methylprednisolone in high dose and remdesivir. But the remdesivir would be ready tomorrow, for example, tomorrow noon. But the patients before remdesivir gets 500 milligrams or 1 gram methylprednisolone, especially I had one pregnant patient recently, 1 gram methylprednisolone, and she had high fever, leukopenia, 1 gram methylprednisolone. And I don't know, even in lupus pneumonitis, we use lesser amount of steroids, But the patients.
I got your point. I got your point. But my point is, we do not have antivirals.
Antiviral.
Remdesivir is
many
not
audience
as Dr. as Dr. Yazdanpanah said, that it's not an antiviral. It cannot do as antiviral in that phase that actually you're talking about. You know, if we use it early as an RDRP inhibitor, it could do something. We have to do some trials for it. You know, it's an RDRP inhibitor. We know that, but in that phase, I mean, in severe case or for sure in critical case, it's not going to work.
Okay.
Because
If some patients consider a real patient, if a patient with mild to moderate disease now refers to you, which drug? Maybe may you please,
just
may you
liquid,
please, nothing, just
liquid,
NSAID and antibiotics.
Paracetamol, and yes, that's it. You know, what I told them is COVID doesn't have any treatment. So this is our options. It's not gonna work for you, but if you want one of them, I'm gonna prescribe it for you. It's, you know.
So it is.
You know,
so it is based upon the patient.
Yes.
Dr. Yazdanpanah, do you hear us? Dr.
Because it doesn't
Yazdanpanah.
work. Dr. Yazdanpanah, what's your opinion?
Dr. Yazdanpanah, do you hear us?
Yeah. I hear you. I wanted to just to finish.
Dr. Yazdanpanah, what age, what medications do you prescribe when a patient with mild or moderate disease refers to you?
So I think that.
And you said, and in your presentation, you said you mentioned some patients at risk of hospitalization. Consider that I am one patient at risk of hospitalization, for example, because of I have so much risk factors, but I know I have mild to moderate disease. Which medication do you prescribe for me?
So first of all, I think that the definition of mild and moderate is extremely difficult because
yeah.
So that is the first thing. The second thing is that a patient. So I hear what Dr. Shokouhi said regarding patients who come with their CT scan. I also heard that. Here, what we do is that a patient who do not need oxygen, the only drug that we may prescribe, the only drug, is monoclonal antibodies, and only to those patients at high risk of evaluating to severe disease, and only within the 5 days after the start of the symptoms. That's the only thing we prescribe. If a patient do not need oxygen, we do not prescribe steroids. We do not prescribe at all remdesivir. It's almost zero here. I know that in the US they do, but we think that we do not agree with that. But we are doing together meta-analysis because we have different results. So in a patient, outpatient, who do not need oxygen, who is not at risk, nothing, who is at risk within 5 days, monoclonals. That's the only thing we do. Because we consider that nothing else has been validated. And I also think that in patients without oxygen, steroids is harmful. And this is results from recovery, because if you look at the results of recovery, you can see that those without oxygen, the effect of steroids is inverse. It's not significant, I think, but it's the other side of the line. So basically, and this issue, we have it here with general practitioner. We have done a huge amount of information. Please do not prescribe steroids to those who do not need oxygen.
Okay. And when you use remdesivir in inpatient disease?
Never.
Never. Especially even in hospitalized patients?
We don't.
Never?
In the beginning, we used it, but we are not anymore using it. In the US, I know that in the UK, 20% of prescriptions are using it. And if I'm not even sure, if, we use it in the beginning, but we don't use it. If there is a place for remdesivir, and that the meta-analysis is going to show it, it's in early hospitalized patients only. When you have ventilation, mechanical ventilation, invasive ventilation, Optiflow, that is sure no impact.
Shall
So we don't
I talk, Dr. Asadi?
Yeah, yeah.
Thank
Dr.
you.
Shokouhi, frankly, to be frank, you do not remdesivir as an outpatient basis?
No.
No?
Wait a minute, please. We actually in National Committee, we have shortage of beds in my country. So because of that, actually, first of all, I disagree with this kind of clinics, okay? But we actually, we pushed and we should do something for these kind of patients, patients with PF ratio around 300, patients with saturation of oxygen around 90, 91, 89, with no place to, admit. For these kind of patients, we agree to open these kind of clinics. These kind of clinics can prescribe. I mean, the doctors over there, like pulmonologists, like ID specialists, like internists, and so on. They can prescribe remdesivir with or without corticosteroid for these kind of patients. I mean, for patients with borderline,
PF ratio.
in borderline, and we don't have any, empty places
Facility.
to admit them. This kind of clinic is for these kind of patients. But as you see, all of the patients right now with 98% of oxygen, they get remdesivir in Iran. I told the committee that it's not gonna work, and unfortunately, these kind of problems, I anticipate that this kind of problem can, unfortunately, taken on. And unfortunately, right now, we do not have any serums in my country. We do not have remdesivir for severe cases that it's indicated to to take the for taking the remdesivir because of some clinics with this kind of indications for remdesivir injection. All 70%, 60% of clinics right now, they actually the patients got remdesivir with oxygen around 98%, 96%, 94%. 60 to 70% of the patients that admit in these clinics. So and we cannot do anything for that, because the doctor said that it's my opinion. I'm a specialist or subspecialist, and my opinion is this, and we cannot change this. And because of this, we have shortage of serums, shortage of drugs here in Iran, because of some, for some trauma patients, we do not have serum, because so many private groups go, in patients' home and inject remdesivir for them. It's crazy here in Iran. Everything is crazy here in Iran, and because of that, I'm so upset for this problem, and I cannot do anything. Not me, neither of us in National Committee can do about this, because right now, as Dr. Yazdanpanah says, the patient needs to get something, and if you do not prescribe this kind of drug for them, they're gonna sue you.
They refer to another physician.
Or they can go to another physician. But for sure, a lot of lawsuits we're gonna have in Iran because of this. Because someone like me, I do not prescribe remdesivir for the patients. And for this, and our patients right now, with some information in internet, in some, with some of my colleagues, they want to use this drug, and they think it's, it's a must for them to use this drug, unfortunately, and I cannot change their opinion. For each patient, I do some effort to to persuade the patient it's not right to get remdesivir right now. You're a mild case or you're a moderate case. It's not a must for you, but unfortunately they cannot
convince them.
Yes, exactly. Yeah, and it's a problem in my country. But my question was something else. Do we have any antivirals here? Here, not in Iran, everywhere. We do not have antivirals. RDRP inhibitors like favipiravir, like remdesivir, like sofosbuvir, like ribavirin, none of them, can.
No, just to respond, you're right.
Yes,
we don't.
yes.
The only
and because of this, we have to have some for in patient with, as you told us, in inflammatory phase. What do you think? Where is the virus? We have viral replication, but it's focal replication. Yes, and we do not have any antivirals to overcome their power to persuade our immunity to actually for some cytokine release and something like that. We have to do something for that viral replication. We do not have any antivirals, but we can actually do some immunomodulation for that lymphocyte that you told us about. That, as you told us, most of the severe and critical cases, if we just take a look to the lymphocyte counts, there are below 500, 400, even 100. But we have to have, or the patient have to have a good lymphocyte actually response to overcome their viral replication. So because of that, we can use some immunomodulation to actually boost our lymphocytes in first of all in their actually count. We can bump up their count with some drug like IL-7 agonist that we do not have here, or we can actually overcome their lymphocytes actually because of I cannot find the word. Lymphocytes, we can use some checkpoint inhibitors to overcome the PD-1, PD-L1 expression on the lymphocytes to bump up their number. It is a theory. I just theorize this kind of things. I mean, no we do not have any antivirals. We have to do something to boost our lymphocyte to overcome the viral replication. And this, in my country, we do not have anything for this. But Dr. Yazdanpanah, I think this you can do over there with, your in your country. You have good, first of all, money for this kind of things, and the other issue is you have actually good hospitals, good car clinics, and good drugs. Actually, we do not have any of this kind of drugs in Iran.
Can I say no? First of all, I want to come back to some of the points. First of all, I think that in Iran we have also good hospitals. We do not have that much more drugs than you have, and I think we should use only drugs that are validated. Or if we are evaluating,
it's your problem. Yes.
Yeah. And this is not a problem in Iran. I think it's everywhere. I think that remdesivir in Iran has become a business to be honest.
Yes, exactly.
And I think that we should at least say that this drug, even if it works, it has a very small effect and only in some patients. And I think that it's a pity, and it makes us sad that patients pay for this drug because it's an expensive drug, and we don't know if it works. And even we know that in some situation it doesn't work. I think that the issue that you said is that sometimes in outpatients, we don't have any drug to give, and patients want drugs. And if we don't give them drugs, they're sad. So that, yes, that is an issue. But again, we should not give a drug and in addition, an expensive drug to someone who doesn't work because he wants. This is something that we face in all the diseases. The other thing that you said that I agree is that you said that in the period when you have pressure in hospitals, outpatients are different from the periods when you do not have pressure. Because as you said, we have done this also in second and third wave. When you don't have that much beds in hospital, you take patients in hospitals much later. And sometimes you put them on oxygen even at home. So in these patients who are at home on oxygen, we can give them steroids and we should give them anticoagulants. So I think that patients, even if they are not at hospital, that is a different issue. It's patients who are at home, but that have some kind of inflammation. That, yes, we can give them. Then one of the points you raised, which is an issue, is that we are giving, probably in the anti-inflammatory phase, we have some kind of viral activation, residual viral active. It is not viremic, as you said, it's in the lungs, but you have it. So we are giving steroids. It seems that you don't have Tossilyzumab in Iran, but I don't know if you have it, but we give them You have it, okay. So we here give them two immunosuppressors without giving any antivirals. Yes, this is an issue, but we don't have any antivirals validated in hospitalization. The only antiviral that has shown efficacy is monoclonals. That's the only one. We should be very careful that they are active against Delta, and the only one active currently, which we have, is Regeneron Roche. I don't know if you have them in Iran.
No, we don't have.
No.
Yeah. Probably you're going to have it because AstraZeneca is coming.
It's very expensive.
Yeah,
Doctor.
that
very
is
expensive, and because of that, they're not going through this.
Yeah,
well, we actually in national committee we talk about this, but because of its price, they cannot gonna make it.
The other option you have, I know that is the issue with this drug, very expensive, is plasma, convalescent plasma. Maybe because you have studies if you give it early, because I don't know if you have plasma convalescent, because that is the control.
Yeah. We have it, but the results of the studies were disappointing, as I know. Yeah, Dr. Shokouhi?
Yes, no. Dr. Yazdanpanah said, talking about mild and moderate cases. I mean, he says that for outpatient. Yes, it's a good actually option for outpatient patients, but because they have to come in hospital, and it's IV. For some logistic problems, it's hard to do. But Dr. Asadi's, as Dr. Asadi said, all of our trials in Iran for plasma, for convalescent plasma, actually they're done for severe and critical cases, and it's not
that doesn't work.
Yes.
That doesn't work. But you have the Argentinian study published in New England that shows if you do it very early, it could be active.
Yes, it could be. Yes.
And that the advantage of this is that the previous producer is the country. You can produce it. So that is the only thing we have. For now, we don't have anything else. But it's not that because we don't have that, we should give something that we don't work. So even if there is a patient want us to give them, I think that is something that is really important because, when it becomes a business, it's really not good.
Actually, it's $1 billion business here in Iran.
Yeah, I know. And that is sad.
For a drug with no efficacy,
Yeah.
no efficacy. Because of that, we have a lot of problems. For Dr. Asadi, you asked me about high-risk patients. Actually, for high-risk patients, I mean, for elderly patients, for patients with obese patient, for hypertension patient, for diabetic patient, and etc. For all of them, actually, we in our national guideline, we have to actually give them an antiviral, an approved antiviral. Actually, we don't have any approved antiviral. In Iran, we just said actually in our national guideline, we just said that we have hydroxychloroquine with no effect, we have favipiravir with no effect, we have ivermectin with no effect, we have sofosbuvir with no effect. Actually, in our guideline, we talk about doxycycline, azithromycin, that please do not prescribe these kind of drugs for the patients. And for these kind of patients, for high-risk patients, yes, I actually told them you have to get one of these prescriptions, but it's not going to work for you. I told them it's not going to work for you, but not remdesivir. Remdesivir, as I told you, just for borderline patient with, dropping PF ratio, for these kind of patient with no place to admission, yes, I actually, send this kind of patient to the clinic with, prescription of remdesivir and actually dexamethasone. The dexamethasone is the main drug for this kind of patient, not remdesivir, and anticoagulant for sure. One question for you, Dr. Yazdanpanah. What's your opinion about anticoagulant for severe cases? You do actually which dose of anticoagulant you use?
Yeah,
after this NEJM
we do
article.
For critical patients, it's mostly prophylaxis dose, and then for
you do this. You for critical cases, you just prescribe prophylactic dose.
Yeah, we don't do curative dose.
And what about severe cases?
In severe cases, I think there is many biases in the New England journal paper.
I agree with you in this.
And if you look at the editorial on that, it says that. So what we do, so we have a large study comparing prophylactic and intermediate. But for severe, yeah. You have done it for critical, but we're doing for severe. We have already enrolled 1,000. But what we do is if the BMI is low, we do prophylactic. If the BMI is high, we do it curative. And if the BMI is average, we do it
individually.
Intermediate, yes.
Intermediate.
Yeah.
So for critical cases, you just give them prophylactic dose, yes?
Yeah, because we did give some curative doses, and we have some hemorrhagic issues. So that's why we stopped.
Even in patients with, some teenage patients, you give them, I mean, not elderly patients.
Yeah, but we have less teenagers. But they also need
adults, some 40-year adults.
Yeah. No, if they are high BMIs, yes, we do higher doses, but if not, no.
And what about your outpatients for regarding anticoagulation? Nothing.
No, we don't do anything because we give it if we have inflammation. Outpatient usually don't have inflammation. If because of bed not available, you hospitalize less frequently your outpatient. In those that you don't admit to hospital but who have inflammation, yes, prophylactic.
For your exhausted patient with, if you have a patient with morbid obesity and your patient is exhausted and cannot, cannot move or something like some patient like this. What about this patient?
That we can give it, because of the underlying conditions, yes.
Okay, so you give them individually, and which kind of anticoagulant you use? Aspirin or DOAC? Which one?
No, not aspirin. We use
NOAC or DOAC?
Yeah.
Okay, low dose.
Low dose, yeah.
Okay.
Dr. Shokouhi and Dr. Yazdanpanah, as we are going to reach to the end of panel and